Uh, I welcome once again, all the residents and faculty members of the Department of Urology, SMS Medical College, and all those viewers who might have joined us, and especially our invitees for today's class, Dr. Madhusudan Agarwal, Dr. A.K. Saval, and Dr. Samir Vyas. Thank you, sir, for joining us. We are really privileged to have you today. So we all know Dr. Madhusudan Agarwal doesn't.
Samir Trivedi, sir, not Vyas.
Yes. Sorry, I'm really sorry, Dr. Samir Trivedi. Dr. Madhusudan Agarwal, I think doesn't need any introduction. He is a past president of Urological Society of India, and he has been, and it is really a proud moment for us that he has also been an SMS alumni. He did his MCH Urology from SMS Medical College, and he has done a lot of pioneering work in endourology, particularly PCNL. And we also have witnessed his workshops on bipolar enucleation of the prostate so many times. So I would not in detail tell you about his publications, awards that he has received, multiple awards, and the accolades that he has been given throughout the country and even abroad. So welcome, Dr. Madhusudan. We are really privileged to have you. Dr. A.K. Saval, he is presently the president of the state chapter of UP and Uttarakhand, Urological Society of India. And again, he has been a very senior urologist. He is presently the director as a consultant in St. Jude's Hospital, and is also attached to the Medical College in Jhansi. And he has, to his credit, a lot of publications, awards, and one particular innovation, that is a nephrostomy dilators, to his credit. So welcome, Dr. Saval. And Dr. Samir Trivedi. Dr. Samir Trivedi is now a professor and head of the Department of Institute of Medical Sciences at Varanasi, BHU. And again, he has to his credit a lot of more than 100 publications and awards. And he has been there for a quite senior urologist. And so welcome, Dr. Samir Trivedi. So we will start our session. The format of the session is Dr. Rahul, who is a first-year resident in our department, will present the case. And Dr. Nishkarsh, the third-year resident, we will discuss the case with him. It will almost like an examination format. So I would request the special invitees to ask him questions regarding the case. And if any clarification or any queries are there, we can discuss it in the class. And then the moderator of today's session is Professor Vinay Tomar sir. And I would request Dr. Tomar to take up this immediately after this. So Dr. Tomar, kindly be our moderator for today's session and invite Dr. Rahul and Dr. Niskarsh for the presentation.
Thank you, Dr. Shivam. First of all, I should say good morning to all invitees, Dr. Madhusudan, Dr. A.K. Saval, and Dr. Trivedi. Now I will invite Rahul to present the case, please. Yes, Rahul, please.
Yes, sir. Good morning to all. So I'm presenting a case of BPH, and our moderator is Dr. Vinay Tomar sir. There is a 64-year-old male which presented to the urology OPD with the chief complaint of increased frequency of micturition since last 1 year, so poor urinary stream since 1 year, and straining for 1 year. So history of present illness, so the patient was apparently asymptomatic 1 year back. Then he started having complaints of increased urinary frequency. The daytime frequency was around 6 to 8 and nighttime was 3 to 4. The increased urinary frequency was insidious since onset and was gradually increasing and reaching up to around 8 to 12 in the daytime and 4 to 5 times in night. Patient also complained of poor urinary flow, which was progressively increasing in severity, and it was associated with straining and intermittency. Patient also complained of feeling of incomplete voiding. The IPSS score was calculated 17. Sir,
Rahul,
sir.
just a minute. Nishkars, do you want to ask any other? I mean, is it complete history, or you want something more? Nishkars,
Yes, sir. Yes.
anything more in the symptoms or the history, present illness you want to know, so that it can lead to your diagnosis and subsequent treatment and management. Anything,
Yes, sir.
anything.
Yes, sir. I want to ask whether any history of fever is there or not.
History of fever.
Yes, sir.
Rahul,
Yes, sir.
history of fever.
No, sir. The negative is, sir, they no history of pyuria or fever, sir, maturia, no episode of any urinary retention, no pelvic or perineal injury, or no history of any catheterization. There is no urgency or any incontinence, no scrotal or perineal pain, no penile or granular lesion. There was no discharge from urethra or perineum. There is no complaint of any trauma, flank pain, or decreased urinary output.
So discuss.
Sir.
Have you gone through the history?
Yes, sir.
Anything important?
Sir, one more thing I want to ask, whether the stream is increasing on straining or is not increasing.
Any importance of this in your diagnosis or treatment?
Yes, sir. Actually, usually in bladder outlet obstruction secondary to stricture disease, it will reduce or it will increase on straining, sir, stream, and on benign enlargement of prostate, it will reduce. Sir.
In all cases, or especially in median lobe enlargement?
Mainly, primarily in median lobe enlargement, sir.
Okay. So the history you complete. Okay.
Sir.
Rahul, go ahead.
Sir. So past history, sir, patient is a known case of hypertension in last 2 years and on medication tablet amlodipine. There is no history of any other morbidity and no history of any surgical process. So
just a minute. Nishkas,
Yes,
is
sir.
there any importance of history of hypertension?
Yes, history of hypertension is important, sir. Around 30 to 40% cases of benign enlargement patient will have hypertension also, sir. And in metabolic syndrome also, high chance of BPH will be there.
Okay. And diabetes, any other past history you want? Any other past history?
History of catheterization is already told, sir.
Already mentioned history of no history of surgery.
Yes, sir. Whether patient is having any history of trauma to the back or any history of any surgery related to spine, sir.
Related to what? He has already mentioned there is no any history, any surgery. Okay.
Yes.
Okay. Rahul, go ahead.
So before we go to the physical examination, I would request our invitees to just give their, if they want to know something or they want to add something to what Dr. Rahul has already said, and is he correct in his presentation, or you would like to modify or suggest something to him? Dr. Madhusudan, please. Dr. Madhusudan.
I think it's okay. You can carry on.
Doctor, okay, thank you. So go ahead, Rahul.
The personal history said they no history of any smoking, tobacco chewing, or any.
No. Okay. Carry on.
The normal bowel habit and sleep cycle, patients completed his family with 2 children, and family history was found to be not significant.
Yeah, just a minute. Nishkars,
Yes,
he
sir.
asked about the history of smoking. Any relevant question? History of alcohol, drug consumptions.
Sir, history of smoking.
Is it important?
Yes, sir. History of smoking and alcohol intake will increase chances of metabolic syndrome, and the metabolic syndrome will have higher chances of BPH, sir.
So will it make any difference on treatment part also?
Sir, in treatment part, sir, the alcohol.
And what? Yes, continue. Carry on.
And sir, smoking is important because it is a the comorbidity will increase, sir. So at the time of surgery, we have to stop smoking.
Okay. Drugs, and what drugs? He should have asked what types of drugs. He has mentioned no any drug concept. Types of drugs should have asked.
Sir,
Hurriedly, yeah? Don't take time.
Sir, any history of sympathomimetic drug consumption, sir? Any history of any anticholinergic drugs, sir?
Oh, any, and then?
Sir, like drug for asthma, sir.
Diuretics also.
Yes,
okay.
Sir.
What about bowel habits? I mean, normal. And
yes, sir. Actually, in constipation, chances of LUTs will be higher, sir.
Okay. And sleep cycle, any importance in personal history?
Sir, sleep cycle, mainly if patient is having nocturia, then sleep cycle will be disturbed, sir. He has to wake up many times.
He has not mentioned history of bony pains in past illness, or present illness, history of present illness. Is it important?
Yes, sir, it is important, sir.
How come?
Bony pains can be there secondary to metastasis from prostate, sir. And CA prostate also is a cause for LUTs, sir.
And he has also not mentioned hesitancy in symptoms. Is it important to notice hesitancy?
Yes, sir, it is important, sir.
How come?
Sir, actually, in a case of obstructive LUTs, patient is having hesitancy, sir.
Okay. Family history, not significant. What significance you can see in the history?
Sir, in case of CA prostate and BPH, both family histories are important, sir. And if patients, any family member is having BPH, then whether he has undergone surgery for that and timing of surgery is also important, sir. Chances will be higher if patients any relative gone surgery before age of 60, sir, for BPH, sir. And in CA prostate also is important, sir.
So anything you want in family history apart from this? Complete?
Yes, sir. And any history of any malignancy is there in family? History of BPH or related surgery, sir.
Anybody else in the house wants to add anything?
So what I will do is, because we have so many three experts with us and we have invited them, I would request Dr. Madhusudan, please add some of your comments in the history. Is there anything that we want to add? Particularly, would you like the resident to take a IPSS score in this patient? Dr. Madhusudan, please.
IPSS. He has mentioned the score.
Okay. Right. Anything else you would like to?
I think this nearly sums up most.
Sums up. Right. So, Dr. Sawal and Dr. Samir, you would like to add something or suggest something to the resident regarding the history?
I would like to ask Dr. Nishkar something, sir.
Yes, please.
The first question he asked on being asked about additional history was history of fever. What was the cause for asking about history of fever?
Sir, this complaining of increasing frequency, I was thinking about UTI, sir.
But you did not ask about burning or dysuria, and that was not mentioned also. Which is more likely, burning or fever?
Burning is more likely, sir.
So I think logical question would be burning or dysuria.
Yes, sir.
And secondly, the IPSS score was mentioned as 17, but the degree of bother was not mentioned. Probably that is a very important factor when you decide the management. The IPSS may be high, but if the patient is not bothered, you may not think about doing something too aggressive.
Yes, sir.
And then some history about fluid intake is important. He has got a lot of frequency both day and night. So whether it correlates with his fluid intake, although we may need a bladder diary later on during the workup, but still during history, taking some idea about the patient's fluid intake is important.
Yes, sir.
So So,
Dr. Saval, you would like to comment anything?
Yes, you have to see patient as a whole, not as only a BPH patient. Overall, his as a academic discussion, we just take academic part, but we have to see the social background of the patient, whether he is able to cope up with surgery, what is his psychological. Many patients are coming to us, they are fit to undergo medical treatment or surgical treatment, but he is not in that background, and sometimes he is not in that psychological mode to accept the treatment. So acceptance of the treatment, and number two is nowadays, which is very important, is a counseling. Counseling part also should be just evaluate and as the patient comes कि उसके रिलेशन कैसे हैं, क्योंकि जो ट्रीटमेंट होता है वो रिलेशन के द्वारा भी होता है, तो वो उसको आपकी बात को पूरी तरह से समझ रहा है कि नहीं समझ रहा है। और उसमें एक बहुत इंपॉर्टेंट चीज जो मिस हुई है वो एलर्जिक हिस्ट्री है। हम लोग बहुत सारी दवाएं देते हैं, तो ही हैज मेंशन्ड देयर इज नो हिस्ट्री ऑफ एनीथिंग बट ड्रग एलर्जी आल्सो एंड साइकोसोशल। जो हम लोग आजकल जो पहला काम करते हैं, पेशेंट की साइकोसोशल बैकग्राउंड भी एसेस करते हैं जस्ट एट द पॉइंट ऑफ हिस्ट्री। So that should also be now should include. Traditionally, we are not including this, but we should try to assess that also in the history.
Yeah. So Dr. Saval, yes, point well taken about the psychosocial history which has to be taken in these patients. And Dr. Sameer mentioned about the bothersome. I think it's a very pertinent point, and Dr. Madhusudan also agrees to it. And that is the difference between IPSS and AUA score also. The AUA includes the bothersome question also in it. And secondly, I think it's very important, the point that was raised about the voiding diary. I feel that voiding diary is a very important thing. Before you go to investigate the patient further, at least a voiding diary is very important, because if the patient has nocturia, so a nocturia predominant symptom would totally change the management of the patient. So it's very important to have a voiding diary, particularly not only nocturia, what Dr. Sameer said about the fluid intake. So if the patient has a habit of kind of psychogenic polydipsia or increased intake of fluid, this patient will have frequency. So I think this is very important and it's well taken. So Dr. Tomar, go ahead and yes, please.
Thank you all the experts for enriching the knowledge. Now, Rahul, continue. Please go ahead.
Yes, sir.
On the examination?
The patient was conscious, oriented, cooperative, and well built and well nourished. So pulse was 76 beats per minute, BP 130/80. So patient was afebrile, respiratory rate was 12. No evidence of any pallor, icterus, clubbing, cyanosis, pedal edema, or any lymphadenopathy, sir. The system examination, respiratory.
Please, just go back. Nishkars, anything you want to add? Dr. Nishkars.
Yes, sir.
Dr. Tomar, let him complete the examination altogether, and then we ask. Examination pura okay.
Okay, go ahead.
The systemic diagnosis, respiratory and CVS system was found to be normal, no abnormality in CNS. So per abdomen was normal and hernial sites were normal, sir. So then local examination, sir. So inspection, so meatus was found to be normal, no evidence of any phimosis with BXO changes, no abnormal discharge periurethral or for perineum, no swelling at the scrotal perineal region. On palpation, there was no local rise of temperature and no tenderness at penile, scrotal and perineal region. No penile induration, perineal sensations were found to be intact and cremastic reflex was present. Digital rectal examination. So anal winking was present, anal tone was found to be normal, and sir, on palpation, sir, there was grade 2 firm prostate, smooth surface, medial sulcus was present, mucosa of the prostate was mobile, and there was no nodule and no tenderness. So BCR was present.
Also, Nishkars, you want to add anything or you want to know anything?
Sir, in any on per abdomen, any suprapubic fullness was there or not?
No, per abdomen finding was normal. The bladder was there.
Did you mention it?
So, per abdomen, sir, was normal.
I think
So
that's the most important thing.
what abnormality you can find on per-abdominal examination?
So any mass, palpable suprapubic fullness, any flanks were examined for anything.
Dr. Nishkash,
Yes, sir.
any importance of BMI?
Sir, yes, sir, it's important, sir.
But I think the examination did not mention about the weight or height. So
Sir,
how
yes,
do you know?
it's mentioned like well built and nourished, sir.
Would that give you an BMI?
No, sir, it won't give me a BMI.
You mentioned about metabolic syndrome during the history taking. That is an important component of LUTs.
Yes, sir.
So probably it's a good idea. This will give you some extra brownie points during the examination if you ask things like these.
Yes, sir.
Nishkash, I think you know about how to measure the BMI.
Yes, sir.
Yes, what is it?
Sir, it's weight upon height in centimeters.
So, Dr. Samir, sometimes the waist circumference is also a very good idea to understand about the BMI. So, what do you think about just measuring the waist circumference would tell exactly if the patient has obesity or a metabolic syndrome kind of thing?
Yes, exactly, sir. The centripetal obesity, the waist circumference gives you a better idea about the possibility of metabolic syndrome and central obesity. So yes, there are many studies now which have correlated it with bloods.
Yes. Yeah.
Nishkash, this metabolic syndrome, does it make any difference in treatment?
Yes, sir. The chances of complication during surgery will be high, sir.
Apart from this, lifestyle changes, that is very important.
Yes, sir.
Change in the lifestyle.
Yes, sir.
Anything extra you want to know? He mentioned no pedal edema. How come this is significant in this examination? Pedal edema.
In case of heart disease, the pedal edema will be there, and patients of heart disease will have higher chances of nocturia.
Okay.
Nishkash, any role of sexual history? Erectile dysfunction, sexual dysfunction, any role of that?
Yes, sir, it's there, sir. First of all, the erectile dysfunction and the sexual dysfunction will be higher in metabolic syndrome, as well as will be higher in LUTs also. And that in treatment part also, we can choose drugs depend on the sexual history, sir.
So that should be asked and confirmed.
Yes, sir.
Okay, all right.
Yes. Nishkash, you are wrong in saying about the BMI. Dr. Prasant has corrected you as weight by meter square, right? Yes, right. So it's very important, BMI, as it has been pointed out. Yes. And the sexual history is again very important, right? It will affect the management also. You have to counsel the patient accordingly, because these alpha blockers can cause some problem. Even the surgery might cause some problem with the sexual function. So it's very important. So point is very well taken that sexual history again is very important. And we know that metabolic syndrome and sexual dysfunction, both have a common pathophysiology with LUTs. So this nitric oxide phenomenon and other Rho kinase pathway, etc., all they have a common pathway which leads to metabolic syndrome, LUTs, and sexual dysfunction. So it's very important to know all these things. Any experts, do you have any other comment on physical examination and history?
I think that's fine.
Yeah. Carry on.
Please, Dr. Tomar, go ahead, please.
Carry on.
Yes, sir.
Rahul?
The investigations, urine examination, the pH was 6.0, specific gravity 1.014, protein with sugars were absent, pus cells were 2 to 3, RBC 1 to 2, epithelial cells were found to be occasionally, crystals and cast were absent, and no evidence of bacteria. So investigations, hemoglobin 11.2, so TLC 7.9 thousand, so platelet 1.95, BTCT and PTNR were within normal range, so renal function test within normal range, serum PSA was 2.9 nanogram per ml, urine examinations, so pulses 2 to 3, RBC 1.2. So USG KU bar with PV, so bilateral kidneys and ureter were normal. So urinary bladder was normal. So prostate was 42 grams and PVR was 20 out of 240 ml. So uroflowmetry, so the flow rate was found to be 12 ml per second. So time to peak flow was 6 seconds. Voiding time was 32 seconds. Average flow rate was 7 ml per second and voided volume was 220 ml and PVR was 20 ml.
Yes, go back. Yes.
Discuss any more information you want in investigations which have been done?
Sir, I want to see USG picture, photo.
USG.
Also, USG photo.
Show the USG slide, huh? Okay.
I want to see the picture, sir. USG picture. Many times the median lobe will be missed in.
Picture is available or not?
No, sir.
Rahul, not available?
No, sir.
Not available. Not. So there was no median lobe. Okay. Go ahead, Nishkash. There was no median lobe. Yes.
Anything else? Any information?
What about
He probably missed, huh? Any importance of detrusor hypertrophy?
Yes, sir. In case of chronic outlet obstruction, the bladder thickness will increase, sir, and the chances of diverticular formation also will be there, sir.
What do you want to know about median lobe?
Sir, he's also having obstructive load, sir. Like weak stream is having, sir. So I want to know if median lobe is there, and treatment part also it will change our management, sir.
Is it helpful in assessing bladder neck obstruction in cases of BPH? Intraprostatic projection of the median lobe? Is it helpful?
Sir, yes, sir, it's helpful, sir. One is the obstruction chances will be higher in bladder outlet if median lobe is there, sir. And it can cause later on irritative loads also, sir.
Any other investigations you want to add? Something else or some other investigation you want?
Here I would just interrupt. I would request the experts to give me some idea about the guidelines. Say that you need not do ultrasound of the upper abdomen. You need not do a uroflowmetry. You need not do a serum creatinine, and serum PSA again has to be done with informed consent. So, any comments about these investigations, Dr. Madhusudan?
I don't see how you can do away with these tests.
Exactly.
So, irrespective of the guidelines.
Yeah. So we routinely do all these things. Though uroflowmetry we may not be doing in every patient, but definitely we are doing a serum creatinine and PSA. Do you actually inform the patient that about the pros and cons of the serum PSA report and then get the serum PSA done, or it is a routine practice?
Our own guidelines. We can't go by these Western guidelines, which are so silly many times. So I think nobody in this country would be taking an informed consent for doing PSA in any case. And I don't see why you shouldn't do uroflowmetry. To my mind, it is one of the most important and significant investigations, because so many times, like the bother symptom, people are severely obstructed and they don't tell you about it. People who are not obstructed, they complain of obstruction. And to my mind, the single most important investigation, which actually tells you the true state of affairs, is uroflowmetry. So there's no way you can skip uroflowmetry.
But uroflowmetry sometimes could be fallacious. Like many a times you see that the uroflowmetry is something different, and the actual urination, what the patient says, may be slightly different. Because when they go for uroflowmetry in a space, a lab, it is very difficult sometimes for the patients to urinate. So it may be fallacious at times. So should we actually totally depend upon the uroflowmetry, or you think otherwise?
I suppose everybody will agree that you can't depend on only one thing. It's always a combination of, it's a whole picture. Like Dr. Sawal said, you have to consider the entire picture in its totality. Correlate the clinical picture with the history and with the investigations. But more importantly, there's something which I always do is when I see a Euroflow report, especially if it shows obstruction, I always ask the patient that, do you void better at other times? So if the patient says that when he did the Euroflow test, he was not able to pass urine satisfactorily, and he's able to void better at other times, I would ask for the test to be repeated.
That's a great idea. Yeah, I think Dr. Sawal and Dr. Samir, would you agree with Dr. Madhusudan that you need to do all these investigations in the first?
I would, sir. Definitely, we can't do without an ultrasound. I mean, I think even the latest EAU guidelines have slightly changed a bit. They are now recommending an ultrasound. Earlier, they used to recommend it only for specific indications. And uroflowmetry, I agree with what Dr. Madhu sir has said. I mean, it's a component of the overall workup, but it gives you very crucial information. So I would definitely do an uroflowmetry in such patients.
So in the first visit only, we will do an ultrasound of the upper abdomen and lower abdomen also, and a creatinine and a serum PSA and a uroflowmetry, right?
And a urine RMs.
And urine routine. Okay. And I think, yes, please. Yes, please. Yes.
We have to screen the patient in nowadays scenario. We don't miss a thing. Actually, uroflowmetry sometimes may be fallacious, but sometimes it's just clinches the diagnosis. Say stricture. Stricture has very typical pattern, box pattern, and all these symptoms patients can tell. And once the uroflowmetry is there, you will catch that no, it is not BPH. BPH may coexist, but main culprit is stricture. So it is these like way ultrasound. Ultrasound sometimes same symptoms can be masqueraded by a hidden malignancies. And sometimes an upper tract also you can have an incidental finding. If you don't get it done, upper tract evaluation, basically patient may blame it. So all these tests also are the screening test. Once somebody comes to you with a voiding symptom, you have to evaluate his upper tract and lower tract. And then you have to, on the basis of history examination, think what is the supposed diagnosis. And I will add, sometimes when doing a cystoscopy is very helpful in such patients, not all the patients, selective patients, where you find more of, sometimes you find a very, very acute prostate. Sometimes you find a very severe cystitis, which can give rise to all these symptoms.
Right. I think what we need to do, probably in my opinion, is to tailor our investigations according to the history and physical examination. And as Dr. Prasant has put in the chat box, that voiding diary again is very important to actually tailor the investigations. Suppose the patient has a nocturnal predominant symptoms or a storage predominant symptoms. I think your investigations would be slightly different when he has a only voiding predominant symptoms. So I think this should be tailored accordingly. Yes. Yes. Any comment?
I want to ask Dr. Nishkar something, sir. He is totally out of the discussion.
Yes, please go ahead. Please go ahead.
You mentioned about the importance of bladder wall thickness.
Yes, sir.
Yeah. So, I mean, what exactly you want to know? You want to know the detrusor wall thickness or the bladder wall thickness? And do you have any idea how do they measure it? Which part of the bladder? What are the conditions?
Yes, sir. The bladder wall thickness is from mucosa to outer layer, sir. And the detrusor wall thickness is in between that mucosa and outer layer. This will be hyperechoic. The hyperechoic area between these two layers will be detrusor muscle, sir. So that will be detrusor wall thickness.
And how do you measure it?
Sorry, I'm so sorry. when would you measure it? On empty bladder or on a full bladder?
Yes, that's what I want.
Sir, bladder should be partially filled, sir. Like 50 to 100 ml only.
It's 150 ml.
Yes, sir.
150 ml anterior bladder wall.
Nishkarsh is not 50 to 100. 50 to 100 is too small. As Dr. Samir said, it must be around 150 to 200 ml so that it is not overstretched and it is not even empty bladder. So it should be in a partially full bladder to measure the bladder wall thickness. And what do you think should be the thickness which will tell you that this is probably obstructed bladder?
Sir, bladder wall thickness, full bladder wall thickness, if it is more than 4 mm, then thickness is higher, sir. And if detrusor wall thickness is more than 0.6 of full wall thickness, then detrusor hypertrophy chances is there, sir.
I didn't get it. Actually, what is the normal thickness of the detrusor wall?
So it will be,
Less than 4.
bladder wall is 4 mm, sir.
Is it normal? I think it's 2 to 3 mm. That is the normal thickness. And if it goes 5 or more than that, that probably it is thick walled bladder or trabeculated bladder. Experts, do you agree with me or?
Yes, sir. More than 5 mm.
Yes.
Based on the criteria which we discussed earlier, is considered to be abnormal.
Right. And there is another parameter which is called bladder weight. Nishkarsh, do you know about the parameter bladder weight and how do you measure the bladder weight?
Sir, I heard about it, but I don't know how to measure it, sir.
So these are very important. These are called non-invasive urodynamic parameters, right? Where you measure about the bladder weight, the bladder wall thickness. Even in the prostate, you have a PCAR ratio. What is that PCAR ratio?
Sir, transitional jaw area ratio, sir.
No. What is PCAR?
Sir, PCAR is C for circumference.
No, it is presumed circle area ratio.
Yes, sir.
Right?
Yes, sir.
So it depends upon the shape of the prostate also, whether this prostate is going to obstruct the bladder or not. So
yes,
this
sir.
is again a very important non-invasive parameter.
Yes.
So yes. And then we have parameters like penile cuff. With penile cuff also you can measure sometimes the pressure with which the urine is coming, and it's again a non-invasive urodynamic method. So these are all. Anything Ed, you want to add, experts?
Dr. Nishkarsh.
Yes, sir.
What is the role of serum PSA testing? Only to rule out malignancy, or is there some other purpose of getting a PSA?
Sir, one is malignancy. Second, it will give idea of prostate volume also, sir.
How?
The PSA will increase on increasing of prostate volume, sir.
So a high PSA means a bigger prostate. Is that what you're saying?
Yes, sir. It is there, sir. The higher the prostate, higher the
Any
PSA
idea
will
about
be there. It won't be in abnormal range, but definitely it will be higher.
Any idea about the effect on disease progression? The role of PSA in predicting the disease progression?
Yes, sir. It's there. Higher PSA will have higher chances of disease progression, sir.
What is the cutoff limit? What is the sir is asking? What is the cutoff limit where you will say that this is higher and there is a chance of disease progression?
Cutoff limit, I suppose.
It is 1.4. More than 1.4 PSA will tell you that this probably will have a disease progression and the patient may require surgery also, right? Or he might require a 5-alpha reductase inhibitor, even if the prostate is not maybe more than 35 grams, but he may require. So that is I think the very important thing of serum PSA in a patient who probably doesn't have CA prostate, but only BPH. And the volume actually will be measured by the ultrasound, right? The PSA would not tell you exactly the volume of the prostate. Yes, it will depend upon the larger the volume, the PSA density would be almost the PSA would rise according to the PSA density. That is true. Anything extra? Anything more?
Dr. Nishkarsh.
Yes, sir.
What would be the most important parameter in uroflowmetry according to you out of all the parameters mentioned there?
Qmax, sir. Peak flow rate.
What should be the normal peak flow rate for a 64-year-old man?
It should be more than 15, sir.
What is the age specific flow rates for males?
Sir, in 80s, it around 5 to 6, it is normal, sir. 64, I don't know.
Sorry?
In 80s, 5 to 6, average flow rate is 5 to 6, sir. The peak flow rate is 5 to 6 in 80s, sir. 60s, I don't know, sir.
See, Nishkash, I think you should, what Dr. Samir was trying to ask you, definitely this QMAX would be age dependent. So you need to know exactly in adults, normal adults, young adults or middle-aged men, what is the peak flow, what is in old age and what is in, so that he was asking. And what about the shape of the curve? Are you satisfied with only these parameters or you want the shape of the curve also?
Shape of the curve is important, sir.
Right?
Normally it is bell-shaped, sir, but in case of any obstruction is there, the voiding will be prolonged, sir, and the peak flow rate and the height of the curve will reduce, sir.
No. How will the shape change?
So,
in suppose there are different causes for decreased flow, right? It could be BPH, it could be stricture, it could be a neurogenic bladder, etc. So how does the shape change in different causes of different symptoms?
Sir, in stricture, it will be box-shaped, sir. And in case of neurogenic disease, intermittency will be there, sir.
Intermittent pattern, yes.
Yes, sir.
And BPH?
BPH is the compressive pattern we'll call, sir.
You call it compressive or a stunted bell?
Stunted bell, sir. Stunted bell.
Anything else from the experts?
How do you differentiate underactive detrusor from an bladder outlet obstruction on uroflowmetry?
No, sir.
On uroflowmetry, is there any difference in the curves?
Yes, sir. In detrusor underactivity, sir, it can be intermittency will be there, sir. Hesitancy can be there, sir.
The time to reach the peak would be significantly prolonged.
Yes, sir.
You see, you hardly get, in a majority of times, you hardly get an ideal curve of BPH. It is basically the interplay of bladder problems as well as prostatic problems. So in many times in BPH, you get small curves showing intermittency. So you have to evaluate the bladder function simultaneously nowadays, because in majority of time, it is not only culprit is not the prostate, it is the prostate, bladder, and overall medical condition of the patients. So you have to see, and you cannot see in only on uroflowmetry. So that thing you have to keep in mind, we don't get an ideal curve only in 10% to 20% of cases. In 80% of the cases, we always get a mixed curve, and you have to interpret and correlate with your symptoms and other investigations.
Okay.
Yeah, I think, yes, Dr. Samal is correct. Every time you do not get the same type of picture, typical bell-shaped or stunted bell shape in BPH. But Nishkash, two things are important here in a uroflowmetry. One is whether you see the volume of the urine, right? If it is less than 150 ml, you would not interpret those results, right? Unless it is more than 150 ml at least. And secondly, sometimes you get an artifact like you. I would ask the experts also what is their experience about the QMAX. Sometimes they would say 20, 25, but the average flow is 4 or 5. And because the machine reads that artifact as a QMAX, which goes about 15, 20, 25, 30. So it is misinterpreted by the machine as the QMAX. Do you agree? Experts?
Correct. So you always have to look at an investigation in the light of the totality and repeat a uroflowmetry wherever there is slightest doubt.
Right. Thank you. So
I think
patient
go ahead.
just pinches his, yes, many times patient pinches his meatus during the voiding, and that time it comes.
Dr. Samal, we are not able to hear your voice. So I would request Dr.
And to that.
I think there's some signal problem with Dr. Saval's. Dr. Tomar, I think I would request you to go ahead with the presentation.
Rahul, please continue.
So now the management.
So any Nishkas, any other investigation you need? Looking to all these investigations in this patient? Is sufficient?
Yes, sir.
Okay.
So how would you manage, before we go to the management slide, we would request Dr. Nishkas to tell us how would you manage this patient now?
Sir, now I'll ask patient for a bladder diary, sir. Whether he is having any bladder diary or not. Rahul, patient is having any bladder diary?
The patient was suggested for bladder diary, but the patient was too illiterate and even their family members were illiterate. He was not able to keep a record of that thing.
So Dr. Nishkas, in that case, can you just have an idea by asking the patient that what is the amount of fluid that is taking and usually what is the usual amount of void that is actually passing?
Yes, sir.
And yes, so whether he is passing more urine during the night time or not. So you can have a rough idea with the history also if he's not doing a full complete voiding diary. Yes.
Yes, sir.
So that is again very important to understand which is more bothersome and which is more predominant, which symptom is more predominant. So he doesn't have a voiding diary. So he has major is a voiding symptom. So that is predominant.
Yes, sir.
How do we manage this patient?
If patient is having predominantly nocturia, sir, then I'll nocturia and polyuria. First, I will ask polyuria and nocturia both, sir. If he's having predominant polyuria or nocturia, then I will ask is what he's consuming, like fluid, amount of fluid, coffee, tea, and any alcohol consumption is there during night or not. And then nocturia predominant is there, then I will ask patient to reduce his fluid intake during night time and avoid alcohol if he's drinking during night, sir. And then I'll see the response, sir. And first of all, I'll ask whether he's having bothersome symptom or not. If bothersome symptoms there, then predominantly polyuria or not. If then nocturia is there, then lifestyle change primarily and reduce fluid intake. And if it is having mainly day and night time both increased frequency and bothersome symptoms, then as I'll change lifestyle change, I'll advise, and along with that, I will advise for one alpha blocker and 5-alpha reductase inhibitor, sir.
For Nishkas,
yes, sir.
What is the pathophysiology of nocturia in this case?
Sir, if fluid intake is high,
how do you know it's high?
I will ask patient, sir.
You will ask, then you will know. Suppose normal intake, and in spite of that, he is having 3-4 number of frequencies during night.
Then he must be having the irritative load cells secondary to.
What is the pathophysiology of nocturnal? I mean, polyuria or what you call nocturia? In BPH, in benign prostatic hyperplasia. Then only you can manage the things. Otherwise, I will manage.
So Nishkash, nocturia is again a part of the symptom of BPH also, right? It could be nocturia, again, could be due to so many reasons, right? It could be due to BPH, it could be due to even non-urological causes. So what Dr. Tomar is asking you, just enumerate the non-urological causes of nocturia.
Yes, sir. The non-urological causes can be congestive heart failure, sir. in that case, during night time, the venous return will increase, sir, and patient will have.
Only. What are the conditions? One is cardiac failure. Yes. Next.
Next is fluid intake higher during night time, sir.
Okay. What else?
Diabetes and so many other.
Yes, sir. Diabetes can cause, sir.
What else? Even a sleep disturbance can cause nocturia?
Yes, sir. Sleep disturbance can cause nocturia, sir.
Have you heard of, suppose a patient is obese patient with a short neck and is having nocturia. What comes in your mind?
So sleep apnea.
What is that called? Full term? It is OSA, obstructive sleep apnea.
Yes,
so
sir.
What would we ask the patient?
About history of snoring, sir.
Yes. So it's very important, right? A very important cause of nocturia. Right.
Yes.
So you will manage this patient. What do you think? Because the patient has a normal fluid intake and he is not having nocturnal polyuria, we take it, and his major symptoms are voiding symptoms, right? And it is bothering him.
Okay,
now tell us, how would you manage?
Sir, I'll discuss with patient. I'll explain the disease and I'll prefer start with medical management, and I'll start with one alpha blocker and one 5-alpha reductase inhibitor. The tamsulosin and dutasteride, sir.
So yes, Dr. Tomar and Dr. Experts, please. Do you think what is yes?
You will start alpha blockers first, okay?
Yes, sir.
If he is symptomatically totally relieved, then you will you would like to add 5-alpha reductase inhibitor?
Yes, sir.
What is the size?
Yes, sir.
What is the size you mentioned?
Ask patient sexual history also, whether he's interested in which type of drug you will like to give alpha blocker. Here comes the role of history of the sexual interest of that patient or sexual performance of the patient.
Yes, sir.
Okay. So alpha blocker with alpha reductase. Suppose patient comes that he has got a small improvement in the wording, but still he's going 3 or 4 times during night. I'm not satisfied with the treatment which you have given. So in this patient, what will you do then next?
Sir, you can add one anticholinergic also, sir.
So you have added anticholinergic and he comes after 2-3 days that flow has decreased down and difficult voiding. Then what will you do in such cases? Because he has got 12 ml per second peak flow.
Yes,
and you
sir.
have given some anticholinergic drug along with the alpha blocker, and his flow is decreased. Many times it happens in clinical practice.
Yes, sir. It happens. Then I'll stop anticholinergic, sir.
Any alternative, any anticholinergic which leads to less, changes in the bladder?
Sir, beta 3 agonist we can add, sir.
So that can be added?
Yes, sir. That can be added, sir.
Any expert comment from all the experts?
Rahul, tell us about the serum PSA. What was the level?
2.9.
2.9. And what was the size of the prostate?
42 grams.
42 grams. Right. So this patient qualifies for a 5-alpha reductase inhibitor, both according to the size of the prostate and the PSA level also, right? So expert, please, do you have any disagreement with what Nishkarsh is saying about the management?
No, not disagreement, sir, but I would like to ask Dr. Nishkarsh about his overall impression of the patient. Now, Nishkarsh, he has got a lot of frequency and
Yes,
he complains of weak flow.
Yes, sir.
And few other obstructive symptoms. His ultrasound shows a bladder capacity of 240 ml. His uroflowmetry shows a bladder capacity of 220 ml. The flow pattern looks reasonably okay for a 64-year-old man. A peak flow of 12 ml per second is reasonably okay.
Yes, sir.
So do you think the bladder capacity is on the lower side? There is something wrong in the bladder? There might be a component of detrusor overactivity or something else.
Yes, sir. It can be there, sir.
How can you be sure, or what can you do to find out whether it is really decreased functional bladder capacity, if not anatomical bladder capacity?
Sir, with bladder diary, we can have an idea of bladder capacity, sir.
But the patient is illiterate, you said. He cannot complete a bladder diary.
Then one is I can ask patient to hold during as time as possible, and that time I can ask patient to void, and what maximum amount is already in that time we can see, or we can just do a ultrasound and can have an idea of what is the volume he is having in his bladder.
Would it have any impact on your management?
Yes, sir. If bladder capacity is low, it means the detrusor is functioning, and the chances of bladder outlet obstruction will be higher than detrusor underactivity. So we can just give whatever management we are giving alpha blocker and 5 alpha reductors. And if we are not sure, then we have to.
When you describe him certain lifestyle changes and behavioral modification, any role of bladder training or things like that?
Bladder training will increase bladder capacity, sir, and the lifestyle modification and alter his fluid intake and all will reduce. We can reduce its frequency, sir.
Yes, and see, his post-void residual is only 20 ml.
Yes, sir.
So he's not holding back a lot of urine. He is able to empty the bladder with a flow rate of 12 ml per second with this pattern. So whether the frequency is on account of obstruction or whether it is on account of something to do with detrusor, that question needs to be answered, and probably that would be key in managing this patient in improving the symptoms. Any role of urodynamics
in this case?
Sir, if patient is not responding to medical management, and as patient's flow rate is educated according to his age, then before going for any invasive management, we can consider for UDS, sir.
Correct. Yes.
Any other comment from the experts regarding the management part?
I think many times there is an element of detrusor overactivity caused by outflow obstruction. And many of these patients respond once they get treatment in the form of alpha blockers alone. So I would say that giving a trial of treatment for outflow obstruction alone for a while may be worthwhile before we go for anything further.
So if you mean to say that, yes, please.
I will give him medical treatment first and see how is the response. And medical treatment also, since he has a 42 gram prostate, and we know that above 30 gram prostate gradually progress. So like he has said, I will add dutasteride to that. Okay, first give alpha blocker. Since he has frequency, give him antimascarin. You can see the response. Main thing is what is bothering him. Since his residual urine is quite good, almost negligible. So if it's okay, it's okay. Otherwise, you keep on adding. I will add dutasteride. Then I will add even tadalafil, 5 milligram OD. And that can also increase his urodynamic function and functional capacity of the bladder along with behavioral modification. And maybe all these things suffice. If it does not suffice, this patient can be subjected to urodynamic study also, because then you know the minute details also. Because main problem is, again, decrease in functional capacity of the bladder along with little obstruction.
So just a point here, looking to the PSA, which is slightly high in this patient, 2.9. Definitely, if it is a BPH with a high PSA, or then the chance of progressing the disease is higher. And we need to counsel the patient accordingly that he might progress and he might require surgery in the future also. But looking to the patient, Indian patients, we have so many times we have found that prostatitis is again one of the elements which is part of these symptoms. Even a chronic prostatitis, it may not be a tender prostate on examination. So if you find a patient like this, which is 2.9 PSA, would you like to add antibiotics, a broad spectrum antibiotics, a course of antibiotics in these patients along with alpha blockers? Experts, please.
Yes, I will.
Okay, I would prefer to see if there are no symptoms of suggestive of UTI or prostatitis, and if his urine RM and other things are totally normal, I would hesitate to prescribe an antibiotic just like that.
I agree with Samir. And as I said, he's an illiterate patient, rural background, maybe not so well off financially. I think we should keep it simple. An alpha blocker with a 5-alpha reductase inhibitor, give sufficient time for the medicine to work. See if the detrusor overactivity, if at all it is there because of the bladder outflow obstruction. If everything settles down, the vast majority of these patients will be okay.
Dr. Nishkars?
Yes, sir.
Suppose you are going to treat with alpha blocker only.
Yes, sir.
With such a patient having frequency, urgency, and all that nocturia. Any choice of alpha blocker?
Sir, I will ask sexual history, and other than that,
You have already taken the history and
I will
any
prefer,
choice.
sir, I will advise tamsulosin, sir, selective alpha blocker, sir.
Why tamsulosin?
Sir is asking if the patient is sexually active and you are prescribing alpha blocker, which alpha blocker you would prescribe?
If sexually active, then I will advise alfuzosin, sir.
Any role of alpha blockers in treating frequency, urgency, any one group having more, affinity to treat irritating symptoms?
Sir, the bladder outlet obstruction will be reduced maximally by silodosin, sir. So silodosin will be more effective, sir.
Are you saying silodosin is more effective than the other two in reducing bladder outlet obstruction? Are there any studies to support that?
It will. There is no significant, but it will reduce maximum. The bladder outlet obstruction index will be reduced maximum by silodosin.
I think efficacy-wise, all the three are more or less the same.
More or less,
it's only the side effect profile, tolerability, which is the key factor in deciding between the three.
Right. And sometimes probably people say that if the nocturia element is predominant, then the silodosin might help a little bit more than the other alpha blockers. So that is one. So this patient is having nocturia, and if it continues even with the lifestyle changes, he might be helped by silodosin. So, Dr. Rahul, just go with the management slide, please.
So, patient was counseled about the condition and the medical management. Patient was prescribed 1 alpha blocker and 5-alpha reductase inhibitor for 1 month and advised for follow-up after 1 month. After 1 month, no significant improvement was noted by the patient. So, patient was again prescribed the same drug and advised follow-up. But patient did not come for follow-up after 1 month. Instead, he visited OPD after 3 months, but he said he was on medication continuously since last 3 months. But still no significant improvement was noted. So patient was counseled about the surgical management, and PORP was performed after taking surgical fitness. Post-operative period was uneventful. A post-operating warning trial was given on 3rd day, which was successful. And the post-operative biopsy was suggestive of benign prostatic hyperplasia.
So, yes, Nishkash, would you agree with the treatment part or the...
Sir, yes, sir. if patient after 4 to 5 months also patient is not having any improvement in his symptoms, then I will advise for surgical management.
So, Dr. Nishkash, let
Yes,
me
sir.
get this right. You want to give him medical treatment for 4 to 5 months before assessing the response to therapy?
Yes, sir. The effect of 5-alpha reductase inhibitor will be maximum in 3 to 6 months, sir.
So, are you waiting for the effect of the results of 5-alpha reductase inhibitors to come into the picture before taking a decision?
Sir, as patient, if patient is coming regularly to our OPD and if within 2 months if it's not not improving, then I'll advise for surgery. But as patient lost follow-up and he came after
See, to
4
me,
months. Yes, sir.
the first, when the patient was prescribed these alpha blocker and 5-ARI for the first time and was advised to follow up at 1 month, that is the usual protocol that we follow. And I think most of the people would agree at 1 month, if the patient is responding, you continue with the same treatment. And if he's not responding, you look at other avenues, either change the medication, think of doing a TURP. But prescribing medications for 4 to 5 months, I mean, to me, it sounds a waste of money and patient's resources. These are expensive medications, and if the effect has to come, 4 weeks is a good enough time.
Yes, sir.
Sir, Madhu, sir?
No, I would say that if somebody is not responding in a month's time, you, like you said, you add something or change the medication. And like Dr. Samal mentioned, this is the time to add drugs which will help him. The decision about surgery would depend on the indication for surgery. I'm not sure whether there was a clear indication for surgery in this patient to begin with. A peak flow of 12 at this age and a residual urine of 20 ml doesn't sound a strong indication for surgery to me, except frequency, which was bothersome, and that needs to be addressed with medication, which was probably not tried before surgery. So this is the time after a month's alpha blocker and 5-alpha reductase when this patient can be given other medications like the beta-3 agonists or maybe even ARIs. So I would agree with Samir that you shouldn't continue the same medication beyond a month, but decision about surgery will depend on the absolute indications for surgery, if they exist.
Right. So at 1 month, if the patient had come and he had no response, so definitely something should have been done at that time, either changing the medication or knowing exactly whether this is actually bothersome to him or not. That is again very important. What Dr. Madhusudan had said. If actually this is bothersome with that kind of flow rate, probably we have to do something for this patient. If the medicines he is not responding to the medications. So what about increasing the strength? Like I've seen many people giving not only 0.8 but 0.4 but 0.8 milligram of tamsulosin or combining 2 alpha blockers if the patient is not responding to 1 alpha blocker. So any take on this by the experts, please?
Sir, I personally don't think these things work. People may be doing them anecdotally, and sometimes there may be isolated cases where they may be responding, but there is no evidence to suggest that such a thing works. So I don't do these juggleries, doubling the dose or adding 2 alpha blockers. At the most, as Dr. Samal said earlier, maybe we can try adding a tadalafil, PD5 inhibitor to an alpha blocker, but not giving 2 alpha blockers. I don't believe in that.
So all experts have the same agreement?
Yes.
Agree with Dr. Samir?
Sorry, Dr. Samal, please.
We don't add to the prescribed doses. Agreed. Fully agreed.
I would like to say one thing here. If you go back to the original research work on these alpha blockers, the dose decision was taken on the basis of the optimum dose. It never said that this is the maximum dose that can be given. The decision about 8 milligrams of silodosin or 0.4 milligram of tamsulosin as the prescribed dose was taken because it was considered the optimum dose. The initial trials were also done with 0.8 milligram, and they showed better response than 0.4, but only slightly better. And it was decided that 0.4 is optimum. So if you increase the dose from 0.4 to 0.8, it will probably give some improvement in flow rates or symptoms as well. But whether it justifies the added cost and maybe added side effects to the majority. So there comes the role of, maybe statistics, that you give it to 100 patients and how many people have improved. And that is why you fall back upon the optimum dose. So there is probably a partial justification to increasing the dose in very selected patients who desire to continue trying medical treatment, who are unwilling for surgery and for a limited period of time. I'm aware of a lot of urologists doing it, prescribing higher doses of alpha blocker, or sometimes even combining two different alpha blockers. And I'm aware of patients reporting benefit. They come back and tell you that, yes, we are okay with 2 drugs or double dose. But I'm sure it should only be prescribed in limited cases because of the added cost and because of added risk of things like postural hypotension, and it only for a limited period of time. But maybe in specific indications. Otherwise, I would agree with what Dr. Samir and Dr. Samuel have said, that it is better to stick to just the standard dose of alpha blocker and add something more. So if frequency is more troublesome, then add
background.
And maybe another group of drugs. And if the problem is especially nocturia, then you can maybe even add something only addressing the nocturia.
Exactly. Yeah, my experience is also that in a specific subset of patients, where these patients have probably not fit for surgery or do not want surgery, at least we can try giving 2 alpha blockers or increasing the dose, and a few patients definitely do improve without increasing the side effect. So there is no harm in trying, at least giving a trial to such patients. Secondly, the point is about.
Sir, I have a
yes,
comment on this,
Nachiket.
sir, please.
Yes, please.
Sir,
please
my comment was, sir, sorry, but I differ inside. This is because all the studies which were previously done on alpha blockers, actually the only rationale for fixing the dose is that, for example, like tamsulosin 0.4 or silodosin 4, is that you get maximum benefit, and if you increase the dose further, then the optimization of benefit to the risk of side effects increase beyond this dose. So that is why there is no, for example, in a 50 kg man and an 80 kg man, the dose of tamsulosin or alfuzosin or silodosin would be fixed. In studies which have been done in which the dose was increased, they found that even though there was a subset of patients in which the symptoms improved, but however that subset was very, very negligible. And there was an exponential increase inside the side effects. So as I think that I'll go with Samir sir on this, that mixing and matching of alpha blockers, they would in studies also have not shown to give that amount of therapeutic benefit. You can get one odd patient which has improved on that, but I'd inside this I'd say that mixing and of alpha blockers in studies definitely has not shown that it is going to improve to the level of significance actually.
Nachiket, yes, we agree with you that routinely it should not be done. It is just in a very specific subset of patients where we can try this. The drug is usually optimized, balancing the side effects and the efficacy. So if the
yes,
side effects,
but the thing is that, because you're such a great HOD that I can argue with you to find that person. In how many persons are you going to escalate the dose? Are you going to escalate that dose inside 200 people to find that person in which you're going to? So that is why there also the studies have been done is that, how many cases, again, to the point of repetition, how many cases do you want to try this addition of alpha blockers to find that 1 or 2 per person which is going to benefit from that. I don't think that would warrant, increasing the dose in, just a, discussion.
Yeah, Nachiket, you are right. Routinely, we should not do. We should counsel if the patient is not responding. We should counsel and that symptoms are bothersome for surgery. But yes, a specific subset where the surgery is not being, cannot be done, then probably we might try. So we should stop this probably discussion now here. The only point is I would ask Dr. Madhusudan, like suppose if the symptoms are bothersome, but the flow rate is 12 and Qmax is 12, there is no post-fight residual, still you would not advise him surgery in this patient?
Only after I have exhausted other means, which means I will put this patient on mirabegron, maybe 50 milligrams a day, and give it adequate time, and maybe give him, if the problem is especially at night, I will ask him to severely restrict his nighttime fluid intake and maybe give him desmopressin for the night if still the nighttime frequency is too much, or maybe give him a sedative if his problem is his sleep cycle. Make sure that his nighttime frequency is not because of some other reason, if that is the only cause of his symptoms. And if it's still not responding, if the medical treatment fails, then of course you can go ahead with surgery.
Exactly. So, yes.
You should try medical treatment rationally before proceeding with surgery, and the indication for surgery should be clear. Only then you should proceed with surgery.
So what I could understand is that if the symptoms are nocturia or more of storage symptoms, then definitely we should try adding this mirabegron or anticholinergic. And if it is just specific voiding symptom which is bothering him, and he is not responding to medication, then I think you also would agree that we need to do surgery. Otherwise, there is no other option left.
Absolutely. If it's obstructive, clearly, then you should.
Definitely. Right. So thank you.
It remains a relative indication. It's absolutely indication of surgery are defined from long time. So in this case, it remains a relative indications, and it is also defined. When the daily activity of the patient bothers so much that he demands surgery, he should demand rather than you embarking upon it. One can go with that. But there is also footnote, and that note is his frequency may remain bothersome later on also despite relief in obstruction, because his functional capacity may improve after the surgery and may not improve.
Exactly. So yes, definitely we agreed that if the symptoms are bothersome, then only we should go ahead. Otherwise, there is no point in going ahead. One question about urodynamic study. Every patient, would you do a urodynamic study before going surgery, or you would select patients? Because nowadays there are people who are suggesting that before going for any invasive surgery, you should do a urodynamic study in every patient. As Dr. Sawal said, that the counseling is very important in these patients. Any comments from the experts?
So this is again defined: too young a patient and too old a patient. In this setup, one can go urodynamics. But the patient which is a 64-year, there is a reasonable, it can go without urodynamic testing. Urodynamic testing should not be done as a blanket investigation in all the patients.
All patients. Right. So I think all the experts agree to this, that not every patient requires a UDS before going for TURP.
No, sir, not every patient. There are well-defined indications which are more or less appropriate. And this patient probably, if he does not respond to medical treatment and change lifestyle modification and everything, and if you're planning for surgery, this patient probably I would like to do a urodynamics before re-evaluating him prior to surgery, what are the main symptoms which are bothering him, whether they are irritative or obstructive. If he continues to have these irritative symptoms, despite being given a beta-3 agonist or antimuscarinics, then I would prefer to do a urodynamics and counsel the patient about what Dr. Sawal said, that these symptoms may persist or they may even aggravate post-URP. The irritative symptoms may actually get aggravated during post-operatively. So for counseling purposes in this patient, I might do a urodynamics if we consider surgery.
So only if there are storage symptoms, how do you know that this chronically obstructed patient may have a hypodetrusor also?
Sir, in this patient, of course, that is another criteria to rule out underactive detrusor, as you said. But in this patient, I am not so convinced about the evidence of obstruction. The pattern of the curve looks all right. The PVR is only 20 ml. So I'm really not too convinced that whether he is having severe obstruction. There is no median lobe. The prostate is only 42 grams. The bladder wall thickness is not being mentioned, so we don't know what is the status. So probably some more evidence needs to be there regarding the obstruction.
Exactly, I really agree with you, because the guidelines now are trying to say that before going for invasive surgery, you should do a urodynamic study. So I agree totally that not every patient may require a urodynamic assay. We have to clinically correlate it and just try to find out whether this patient requires a UDSM. Any comment from anybody?
I think the old thing that let the patient earn his operation to prostate, I think it stands. But it's interesting that we've spent 1.5 hours on a simple, straightforward case.
So you can go ahead even for 1 more hour, maybe. I don't know. But yes, we have crossed the time now. So we will have last comments from our moderator, Dr. Tomar, and then we will wind up. Yes.
So I'm very much thankful to Dr. Madhusudan Agrawal, Dr. Samwal, and Dr. Trivedi for enriching the knowledge of all of us, especially residents, and making plan how to manage BPH patients. We are really thankful. Thank you. Thanks to all.
Thank you. Thank you. Bye.
Thank you. Thank you, all the experts, for having shared your valuable time. Thank you. Thanks a lot. And a very good day.
Thank you.
Thank you, sir.
Thank you.
Thank you.
Thanks for inviting us.
Thank you.
Thank you. Thank you.
Thank you, sir. Bye-bye, sir.
Thank you, sir. Thank you.
Bye. Bye.